Well, welcome everyone to the EKG case for the week of December 25th. Merry Christmas, everyone. Hope everyone is enjoying the day. And, well, I guess this is a holiday gift for you, although many of you probably will be listening to this after Christmas. Regardless, this is a great, great case to make you feel a little bit better about the holiday season. So let's move forward with this case. We had a 7-year-old boy that was referred to University of Maryland from his doctor in England, and kind of unusual to get these type of referrals, but anyway, he came on in. And just a little background information about him. So a wonderful little boy. It's a bit frail and sickly looking, however, and walked with crutches. He had short limbs and stature and had a history of some prior fractures, but he had a normal mental status, didn't look acutely ill, and he had just the most positive attitude about life. Just a wonderful, wonderful kid. And so what do you do? What type of test do you do? Well, of course, the first thing that you're going to do is get an EKG, right? Well, why not? Otherwise, we wouldn't be here talking about this. And probably what's jumping out at you about this particular EKG is the fact that there is a prolonged QT interval. All right, so we're going to talk a little bit about a prolonged QT here. And why do we worry at all about a prolonged QT? Well, the prolonged QT can signal some underlying problems, and it also puts people at risk for ventricular dysrhythmias. In particular, we worry about torsade de pointe. We talked a bit about that last week. Specifically, we're talking about mimics of torsade, but this prolonged QT, if somebody really has a prolonged QT, then they can develop the real thing, the deadly torsade. Now, patients are at risk for torsade when they actually have not just a prolonged QT, but a prolonged corrected QT. And as you recall, we've talked about this before, but as you recall, we will correct the QT based on the patient's heart rate, and that's referred to as the QTC. And there's this formula called the Bazet formula, which is probably the most common amongst a few different formulas that are used to calculate this using this correction factor. And some of the purists out there might tell you that you should be using Bazet's formula and calculating it yourself, and I think that's crazy. Nobody's got time to do that. Your EKG machine is actually pretty good at calculating that Bazet formula for you. So this is one part of the EKG interpretation that I'll actually use, and that is the intervals that the EKG machine provides you. Now, if you have an EKG machine that doesn't do this calculation for you, or if there's so much artifact on the 12-lead EKG that you don't think you can rely on the EKG's calculations, then the simple way of doing this just using your eyes is you take a look at the R to R distance, and you go halfway between the R to R distance, and the T wave should end before that halfway point. If you have a T wave that ends after the halfway point, you can see in this particular case the T wave is ending right around there. That's beyond the halfway point. That means that the QT is too long. This is a prolonged QT, and you can just guesstimate it by looking at it and seeing the T wave ends beyond that halfway point. If we go back to the case that I showed you just a second ago, you take an R to R interval and you bisect that about halfway between the R to R intervals, right around there, and you can see that the T wave is ending beyond the halfway point. That means that this patient has a prolonged QT. So even if you didn't figure it out by looking at the EKG machine's interpretation, it's clearly prolonged when you simply look at this. And so the patient has a prolonged QT, and we'll blow it up here a little bit. And there's about the halfway point, and you can see that the T wave is ending beyond the halfway point. So really important, this is an important differential to keep in mind. When you see a prolonged QT, what kind of things should you be thinking about? Well, think about the hypoelectrolytes, hypo-K, hypomag, and hypocalcemia. Those are real important because you know what? You can check those in the emergency department. You can oftentimes even fix them during that shift. So those are correctable things. You also want to take a really good look at the patient's medication list. There's a lot of sodium channel blockers that can be deadly when they cause a prolonged QT. So when you see a prolonged QT, take an extra few minutes and really scrutinize their list of medications. Look them up on the computer for ones that caused a prolonged QT, and consider talking to the doctor about changing their medications. You don't want to leave somebody on a medication that prolongs their QT because you're leaving them at risk for arrhythmias. And then there's a handful of other things that prolong the QT. Elevated intracranial pressure, acute coronary syndrome, in other words, acute cardiac ischemia can prolong the QT. Hypothermia prolongs just about all of the intervals. And then if you don't come up with any other good reason for a prolonged QT, then by default it ends up being referred to as congenital or hereditary prolonged QT. But that's a nice differential to keep in mind. Once again, the most important things from the emergency department standpoint is to think about numbers 1, 2, 3, and 4 in that differential, because those are things that you can actually fix during your shift. All right. So moving forward, let's look at a few other examples of prolonged QT. Now, here's a patient with acute cardiac ischemia who's got a prolonged QT, and let's just ignore the T-wave inversions for this case. Just take a look at the fact that the patient has a prolonged QT interval. All right, the QT interval is prolonged, and there's the QT interval right there. But I want you to focus on the fact that the prolonged QT is really caused by a wide T wave. Let me blow that up for you also. In most cases, when a patient has a prolonged QT, it's primarily caused by stretching out of the T wave. So the T wave got stretched out, and that's why the patient has a prolonged QT. Now look at this case in contrast. In this particular case, again, ignore the flipped T waves. In this particular example of prolonged QT, the patient's T wave is actually pretty normal in appearance. I'll blow that up for you also. So the T wave duration is pretty much normal. The reason that this patient has a prolonged QT is because the ST segment preferentially got stretched out. And that's a really important thing to notice. Normal T wave, but the prolonged QT is specifically because the ST segment got stretched out. In that differential for prolonged QT that I showed you just a minute ago, there's only two things that prolong the QT by stretching the ST segment: hypothermia and hypocalcemia. Those are the only two things in that differential that prolong the QT by stretching the ST segment. Everything else prolongs the QT by stretching the T wave. So if you ever look at a 12-lead EKG and you say, you know what, there's a prolonged QT, but the T wave looks normal, it's just that the ST segment is stretched out. In all likelihood, is hypocalcemia. You can go ahead and call it hypocalcemia. In fact, go ahead and start treating the hypocalcemia. You can start treating the hypocalcemia an hour before the labs come back and confirm clinically what you've already diagnosed. People will be amazed at your magical powers of interpreting the 12-lead EKG. You'll look like a star diagnosing an electrolyte abnormality so far ahead of time. All right, let's look at some more examples. Here's another example. Take a look. Severe hypocalcemia. You'll notice that the T wave is completely normal in appearance, but there's simply a long ST segment. Here's another example. Once again, a prolonged QT, and we'll look at the inferior leads here. The T wave is just perfectly nice and normal. It's the ST segment that's preferentially stretched out. All right, so when you see that, you know you're looking at hypocalcemia. Let's go back to the case, that 7-year-old child that we were talking about a few minutes ago. If you look at his prolonged QT, you'll notice that the T wave looks perfectly normal. It's just the ST segment which is preferentially prolonged. We'll look at another lead up here. All right, T wave looks normal. It's just the ST segment which is really stretched out. And again, this is a blown up example. T wave's normal, ST segment is what is stretched out. So when you see that, you're looking at hypocalcemia. And this kid had a calcium of 5.5 milligrams per deciliter. Normal value should be at least 9 to 10.5 milligrams per deciliter. It turned out that this kid had rickets, believe it or not. 7-year-old referred to you by his doctor in England. Frail, walking with crutches, short limbs in stature, prior fractures, normal mental status, and a very, very positive attitude about life. Who is this kid? Who is this kid who has these terrible problems and yet is so positive about life? Well, hopefully I'm not violating HIPAA by telling you his name. His name is Tim. Some people know him as Tiny Tim. And if you take a look at some of the interesting trivia, a lot of physicians have actually examined that movie, A Christmas Carol, and talked about Tiny Tim, and most people believe that he was suffering from either renal tubular acidosis or rickets. In either case, he probably had hypocalcemia, and that was probably his EKG that I just showed you a second ago. Maybe not, but who cares? It's a great Christmas case. And so I figured we'd just talk about Tiny Tim. So, Merry Christmas, everyone. Hope that was a little, somewhat interesting and appropriate for the season at hand. And in fact, I believe that American Christmas Carol, or one of those versions of Christmas carols on TV right now, so I'm going to go watch. But hope you all have a great Christmas and a great New Year. And I will talk to you next year. As Tiny Tim himself said, God bless one and all, or something like that. I don't know. He said something like that. So enjoy the holiday, and I will talk to you next week. Bye for now.